Hello, everyone, and welcome. Thank you for joining the Scleroderma Foundation's Virtual University Patient Education Fall Series. Today's event is titled The Importance of Sleep When Living with a Chronic Lung Disease. My name is Kerry Conley. I am the Director of Programs and Services for the Scleroderma Foundation's National Office and one of the many organizers for today's event. Before we get started, I wanted to share some quick notes on today's event. If you are properly logged into the webinar, you should be seeing the slide and the presenter on the screen and hearing my voice. If you have dialed into the event by phone, please turn the computer microphone down to avoid any sound feedback. If you are using a handheld device, you may be required to swipe either right or left to view the full screen. Today's webinar is being recorded and it will be made available after its broadcast. The Scleroderma Foundation in no way endorses any drugs, treatments, clinical trials, studies referenced in today's webinar. Information is provided to keep the listeners informed. Because the manifestations and severity of scleroderma vary among individuals, personalized medical management is essential. Therefore, it is strongly recommended that all drugs and treatments be discussed with the individual's physician for proper evaluation and treatment. This webinar is for educational purposes only. We encourage all attendees to use the question and chat feature opportunity on the sidebar. Team members from our national staff will be hosting a question and answer segment at the end of the presentation. So let's get started. I am happy to introduce today's speaker, Dr. Mihaela Teodorescu, also known to her patients as To the Rescue. Dr. Mihaela Teodorescu is the professor in the Division of Allergy, Pulmonary, and Critical Care Medicine and the Wisconsin Sleep and Consciousness Center at the University of Wisconsin-Madison. She also serves as the director of the James B. Scatrid Pulmonary Sleep Research Laboratory at the William S. Middleton VA Hospital in Madison, Wisconsin. Dr. To the Rescue, 17 plus years, has focused on the reciprocal interaction of obstructive sleep apnea with chronic lung disease. She has presented at and chaired multiple scientific symposia, discussion groups, and poster sessions, including international meetings. She has gained expertise and channeled her efforts to better care for the patients through cutting-edge research, education, and teaching of the next generation of pulmonary providers. Welcome and thank you for joining us today, Dr. Teodorescu.
Thank you very much to the organizer for this invitation and giving me the opportunity to provide education on sleep, a very topical topic, I think, for the scleroderma patients, for reasons that you will recognize as we go through the talk. I have no disclosures other than I am currently funded by the Boehringer Ingelheim to study the relationship between sleep apnea and idiopathic pulmonary fibrosis as it relates to response to antifibrotic medications. And the rest of my funding is from the US Department of Veterans Affairs. My goal today is to inform you, educate you in great part about sleep, sleep characteristics and sleep disorders, to try to emphasize why it's important to achieve a healthy sleep. And then focus a little bit on what we know on the relationship between sleep disorders and chronic lung disease that are relevant to the disease you guys are all interested. Given the most common involvement is pulmonary fibrosis, I will review in more detail this relationship between sleep apnea and pulmonary fibrosis because I think it's relevant to any interstitial lung disease, as a matter of fact. So just going into the basic sleep and sleep disorders, as you all know, sleep is a universal phenomenon. It is the state that occurs recurrently and characterized by altered consciousness and inhibited both sensory activity as well as effector activity of universally all the muscles in great part. It is characterized also by reduced interaction with the surrounding environment. However, what differentiates it from other states of altered consciousness, such as hibernation, in humans, anesthesia, coma, stupor, is that it is rapidly reversed to wakefulness upon stimuli. It is universal across phylogeny. Not only humans sleep, but any animal or any species that has been studied, starting with a fruit fly, and these are the honeybees, all across the mammalian, regardless of the size. Sleep is a universal phenomenon, and in humans, at least, it occupies a third of our life. Out of 24 hours, a human should sleep somewhere, as we'll go over, 7 to 8 hours to achieve a healthy life. Sleep is actually a very active, neurologically a very active process. It is, in contrary to earliest belief, that is just simply a withdrawal of wakefulness. It is not the case at all. It is tightly regulated by different centers located in the CNS, thalamus, hypothalamus, the cortex takes part. And the reason is that it's an active dynamic processes. It starts with lighter stages of sleep. We call that non-rapid eye movement stages. And as the night sets in, as the sleep period sets in, you go from lighter to deeper stages of sleep. Somewhere about 1 hour or so, you achieve the deepest stage of sleep. We call that slow wave sleep, where the breathing and most of the functions, other physiological functions, are the most stable. So it's the most physiologically stable stage of sleep, and as a result, is the hardest to wake up from. And as the night progresses, 90 minutes or so, you go into the first period of rapid eye movement sleep. In contrast, this is a very dynamic, very active brain phenomenon regulated by its own centers in the brainstem. Where most of the functions, particularly the cardiopulmonary functions, are very erratic and unstable, and therefore, as you can anticipate, can predispose to more adverse outcomes during REM stage of sleep. And as you can see, as the night progresses, there is gradual reduction in the deeper stages of sleep that become replaced more and more with and longer periods of REM sleep. And the reason is, again, developmentally, REM is the stage where most of the dreaming occur and is the most refreshing sensation, such that developmentally we are programmed to wake up from REM sleep in order to feel most refreshed. So overall, this rapid recurrent nature, it's controlled very tightly in the CNS, as you can see, this is the ideal healthy, what we call sleep architecture, that it's probably from a young adult, what we see in the real world, it's far from this, and it's because every aspect, not only the quantity, but the quality, the timing, the regularity, and of course the absence of disturbances are very important. So maintaining all these characteristics into the sleep architecture, that's the goal of a healthy sleep. We get this question a lot: how much should we sleep? And definitely that varies across the developmental spectrum. Here is a snapshot from the adult spectrum, young adults and older adults. And as you can see, on average, in adults, the amount of sleep that we need is fairly stable. Somewhere around, on average, 7 hours. It drops a little bit in older adult, but overall, during adulthood, the sleep needs are quite stable. What is important is that there is individual variability, as I showed, as you could see here, quite a lot of individual variability, and that's what determines how much you sleep, whether plays a role in adverse outcomes. And it has been shown that there is a inverse relationship with the mortality, such that the survival drops with shorter sleep times. This is in reference to the normal, what's considered 7 hours. So in short sleepers, for example, those who sleep 5 hours a day, particularly in the young, you can see that the risk for mortality is higher if you sleep short. Similarly, if you have a long sleep time, and here there is not entirely a consensus, but in this paper they categorize that variable by 8 hours. Most often is 9 hours. Similarly, there is an increased mortality, particularly in the young adulthood. And of course, these relationships were not as strong in the very old, where the sample size in general is difficult to be enhanced. So overall, just keep in mind that the mortality tends to go up with shorter and longer sleep duration, such that the current recommendations, which are entirely based on expert panel consensus, based on review of the literature, the current recommended standard of optimal sleep is somewhere 7 to 9 hours for the young adult, and in the older adult, over 65, 7 to 8 hours, but not really far different. In contrast, look in children, the duration of sleep is far higher, and that subsides with aging, but definitely in adulthood seems to be the recommended sleep time, it's somewhat more stable. The function, why do we sleep? This is, you can go in a debate about that. So there are multiple hypotheses. I do not have the time to go in all of them, but as one of the parents of the sleep medicine field, Alan Rechtschaffen, said, when, after he discovered the REM sleep, this is the father of REM sleep, sleep has to serve an absolutely vital function. Otherwise, it is the biggest mistake the evolutionary process has ever made. And frankly, as patients and especially providers, we are learning about the function of sleep mainly through disease. And what we know so far is that sleep loss or disturbance leads to cognitive and physical performance. I'm learning and memory, and I just wanted to show down here how various perturbations in these domains have caused definitely to not a very productive work schedule here, and some of the biggest occupational disasters that have taken place in the history have been related to sleep disturbance in various domains. This is the Challenger explosion that took place, I believe, in the 80s. This is the Chernobyl disaster that took place in 85 or 86. I was very close, through my ancestry, very close to that place. These are the Exxon Valdez spill off the coast of Alaska, and more recently, the train crash that occurred in upstate New York. All of them were related to sleep impairment. And there is plenty of literature to emphasize the role of sleep in mental health. It actually is a bidirectional relationship. And let's focus somewhat on physical health, bringing it closer to the focus of this topic. Numerous human domains are affected by sleep and circadian disturbance. Starting the best studied one is the cardiovascular disease. There is strong association with systemic as well as pulmonary hypertension, congestive heart failure, stroke, heart attacks, arrhythmias, you name it. Neurocognitive alterations, which I alluded to, performance issue, but more recently, recognition of a role of sleep disturbance in Alzheimer and neurodegeneration. Metabolic disturbance, including insulin resistance, frank diabetes, and contribution to obesity. GI disturbance, strong relationship with reflux, which is actually highly relevant to this audience, peptic ulcer as well, nocturia, and urologic issues, including impotence. And most recently, the new kid on the block is a relationship with cancer. We know most about solid organs, but hematologic cancer may be also related. And as relates to the respiratory system, unfortunately, sleep also has a major detrimental role given the inherent physiologic consequences that sleep has on the respiratory control system, which I would like to briefly review with you in a very simplistic way. This is a graphic depiction of the breathing control. It's a very tightly regulated closed loop feedback system. Information is collected by the various sensors that are stimulated by pressure, gases, motion, but most importantly, gases, CO2, O2, and their end result pH. Information is collected at multiple levels, gases particularly at the carotid body and in the brainstem, and the information is sent upright to the breathing control, the processor, which is located in the brainstem. And in turn, impulses are sent downstream to the effectors, which are respiratory muscles. These include the upper airway muscles, not only the chest wall muscles, and their movement in the end leads to chest expansion, leads to dilation of the upper airway. Airflow goes into the lung, and lung is being expanded, and gas exchange occur, and the cycle repeats itself. What is very important is that during wakefulness, this whole system, but particularly the brainstem controller, receives very tonic stimuli from the above CNS structures, telling it, breathe, 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 stimulus, a very potent stimulus. We call that wakefulness stimulus. And what sleep is actually very good at, taking away that wakefulness stimulus, which leads, as you can imagine, to a dependence of the respiratory function entirely on the sensorial function, not receiving the stimulus, and particularly from the chemoreceptors. So breathing during sleep is entirely dependent on the gases. And what further plays a role is that not only the CO2 and O2 dependence occurs, the hypoxic and hypercarbic respiratory responses are also downregulated. So just think about when you go to sleep, everything relaxes, and with that, everything that controls breathing. So therefore, in order to produce the same amount from wakefulness to deeper stages of sleep and REM sleep, in order to produce the same amount of minute ventilation, let's say to increase your minute ventilation from 10 to 15, you will need to increase your carbon dioxide a whole lot more with transition from wakefulness to non-REM sleep. So the responsiveness of hypercarbic respiratory responses is attenuated. Similarly, just for cartoon purposes, depicted here is the hypoxic respiratory responses. What that means, in order to increase your minute ventilation, let's say from 10 to 15 here, you have to desaturate a whole lot more from wakefulness to non-REM sleep. So just keep that in mind as we will go through the next slides. In addition to the attenuation in gas responses, as I mentioned, when you go to sleep, everybody, particularly the muscles, relax as well. And this is due to the fact that any neuron in the body that innervates a muscle under wakefulness condition receives a balance of excitatory and inhibitory inputs. As I mentioned before, all the excitatory inputs, not only in the CNS, but also the motoneuron level, are taken away by sleep. So therefore, there is a predominance of inhibitory inputs that would act unbalanced, unopposed at the muscles level, leading to gradual decrement in the muscle activity, and respiratory muscles are not spared. The consequence of this motoneuron, what we call disfacilitation, is depicted graphically here. As you can see, from wakefulness to sleep, all the respiratory muscle, including the upper airway muscles, particularly the tongue muscle, so-called genioglossus. I'm going to talk more about this in a little bit, but this is really the valve that keeps the entire respiratory system open. If you close off this valve, the rest of the pump is useless. So, this pump is affected to a great degree. This valve, I'm sorry, is affected to a great degree by the sleep occurrence, and all the other respiratory muscle, intercostals, the upper abdominal muscles are affected to a similar degree. The only one that is partially protected is the diaphragm. We believe this is a protective mechanism to allow us to breathe, because during REM sleep, I forgot to mention here, complete muscle atonia occurs. So if all the muscles here during REM sleep would become atonic, such these upper ones become, we would not be able to sleep. So the partial protection of the diaphragmatic function during sleep, REM sleep, it's key to survival. Imagine in people with chronic respiratory disease, where the diaphragm function is either lost due to, let's say, phrenic nerve dysfunction, or it's adversely influenced by lung expansion or hyperinflation, such as occurs with emphysema. Because of the dysfunction of the diaphragm, those patients would be at great vulnerability for sleep breathing disorder and frank respiratory failure during REM sleep. And we'll talk more about that. This is again just to depict the importance of sleep affecting all the respiratory muscle, and the importance of the valve and the pump components, how they are all affected in synchrony, except the diaphragm that is only partly affected during REM. So the clinical relevance of all these motoneuron changes are that during sleep, we entirely depend on the diaphragm during REM sleep, and there is quite profound airway narrowing in the upper airway, and we'll talk more about that, particularly during REM. In addition to the withdrawal of wakefulness stimulus that has consequences, as we talked about, on the muscle, indirectly then impacting the lung volumes, as well as the increase in upper airway resistance. There is, as we discussed, alteration in respiratory chemoreflexes. There are some others, but not as potent, factors that influence breathing activity during sleep. There is some changes in the pattern of neuronal discharges in the CNS controller that translates to some extent in an initial reduction in the breathing frequency. However, during REM sleep, that is very variable. The breathing function is very variable. So overall, for the entire night across all sleep stages, there is no significant, statistically significant alteration in breathing frequency. And as you know, when you go to sleep, very intrinsically linked to the circadian factor is a drop in the temperature that's regulated by the hypothalamus, and that leads to a reduction in the metabolic rate, which is another adaptive protective phenomenon, so that we produce less CO2 during the night. So overall, all these changes in the respiratory system lead to some degree of hypoventilation that is defined by a rise in the arterial carbon dioxide to about this range, and a mild reduction in the arterial O2 during sleep. However, these changes in a normal patient, in a normal individual, are not relevant clinically, in the sense they have no consequences because of this very well-known characterized phenomenon called the oxygen hemoglobin dissociation curve, which is, just to briefly go over it, it has a very well-established S-shaped, and here is just the degree of drop in the arterial O2 and how that translates in the degree of arterial desaturation. So for a normal host, let's say individuals with normal pulmonary reserve and pulmonary function, their PaO2 lives around just above 100. And during wakefulness, they live on this very flat portion of the curve. When they go to sleep, as I mentioned, some degree of sleep hypoventilation occurs. And even if the PaO2 drops by, let's say, 10 or 20, millimeters of mercury in the PaO2, that really doesn't change much what happens with the degree of oxygen saturation, because they are still going to be staying on this flat portion of the curve. However, in patients who have limited cardiopulmonary reserve at baseline during wakefulness with PaO2 around 80, and many of my patients are in that, category. They really live right on the edge between the flat and the sharp, abrupt portion of the curve. So the same degree of decrement in the PaO2 that occurs here in the normal host with occurrence of sleep, these patients are going to desaturate profoundly during sleep. So they can bottom down, particularly during REM sleep, as I mentioned before, quite significantly. So the gas exchange at baseline during wakefulness gives you a very important clue what happens during sleep. And in many clinical populations, COPD, IPF, pulmonary hypertension, it has been shown that the degree of sleep desaturation correlates best with survival, much better than any exercise desaturation that you submit these patients, including cardiopulmonary treadmill exercising. We'll talk more about that. But to summarize, the sleep is a vulnerable time for the patient with respiratory disease, and their baseline function while awake gives you an important clue of what they may do during sleep. Now, transitioning a little bit in the most common sleep disorders, I'm sure many of you know and have experiences and maybe questions about these. Insomnia is by far the most common. The prevalence really varies by the setting, general population as opposed to various specialty clinic populations. Sleep apnea is, however, catching up. It used to be, we'll talk about the prevalence, how this is actually going to take a more forefront role in the burden of sleep disorders. And then restless legs are quite common, very unrecognized. And narcolepsy, we were talking before, it's essentially an autoimmune CNS hypersomnia. Fortunately, is very uncommon, less common, because it can be very debilitating. So let's focus a little bit on the breathing disorders. These are perhaps the best understood, and I think they are the most relevant to this audience. The spectrum of what we call obstructive sleep disorder breathing, of which sleep apnea is part of, it's actually a continuum. It starts with snoring, when becomes frequent, meaning occurs at least 3 nights a week, becomes more and more problematic, and the spectrum progresses to what we call upper airway resistance syndrome. Prevalence of that is not quite known, and then becomes obstructive sleep apnea, which is the breathing disorder diagnosed based on a sleep study, and I'm going to talk about that, and then becomes the clinical disease, which is the breathing disorder associated with symptoms. Most common symptom is daytime sleepiness. So we are literally, as physicians, have the resources, I should say, and to deal with the tip of the iceberg. There's lots of disease that's out there and left unrecognized. That's the purpose of all these educational initiatives and I'm happy to be part of. In terms of the prevalence, as I mentioned, sleep apnea is poised, unfortunately, to take more of a forefront role in the sleep pathology. The reason is depicted right in this graph. This is data from the largest and best characterized sleep cohort we have in the world right here in Wisconsin. Or that was established in 1980s right here at the university. They follow these individuals. They've been following them since 1989. As you can see here, with sleep studies in laboratory performed every 4 years. They publish data on their initial period on sleep apnea established at the sleep study level. And we'll talk more about that. And here is the clinical syndrome, sleep apnea with symptoms. So 2 time periods that they published on, and you can see that regardless of the gender, the sleep apnea prevalence has increased regardless of how you look at it, such that the current estimates are about 10, 13%, 14% of the adult population in the US has clinically significant obstructive sleep apnea in general population. And as you can see here, the driving factor, not surprisingly, is the epidemic of obesity. And we will talk more about that, but also aging. So you can see that concomitantly with the rise in epidemic of obesity, there is a very nice parallel rise in the clinically significant obstructive sleep apnea defined at a different level. So overall, right here in the US and right here in Wisconsin, where I am, very encouraging, we are experiencing an epidemic of sleep apnea. But what is sleep apnea? In fact, sleep apnea is a quite fascinating disease. Again, we are paying a price as humans for the evolutionary process, which allows us to speak and perform all these higher functions that only humans can do: speaking, singing, playing instruments, you name it. In order to perform all these highly controlled functions, we really need a collapsible upper airway. That means that in humans, in between the nasal bone, in this region right behind the tongue, between the nasal bone and the vocal cords, the airway has no bones or cartilages to keep it open. So therefore, the function of all these structures that compose it is going to be very important in determining the upper airway patency, particularly the muscles. And I mentioned that the tongue muscle, which pulls forward the tongue, is the main upper airway dilator, but then any additional tissues that can accumulate in the area, be it tonsils, adenoids like in children, fat, fluid, excessive fluid can influence the upper airway patency, and very importantly, the balance of forces and pressures that are created between the nose, the nasal cavity, and the chest pump, as we'll be talking farther down. But nevertheless, this is the region of interest. This is where sleep apnea occurs, and it's not a very long tube, but it can occur at multiple levels along that tube. As a result of upper airway closure, as you can see here, there is no airflow. So you can generate whatever effort you can. There will be no flow to the lung in order to exchange gases. So the upper airway is really the valve in path of the in path of the airflow. So why does sleep apnea occurs? I mentioned before, and here is imaging depiction of what happens with the upper airway calibers, the transition from wakefulness to sleep. Sleep by withdrawal of that stimulus we talked about. deactivates the upper airway muscles, leading to quite significant narrowing and therefore increase in upper airway resistance. So it's very common that the upper airway resistance, which we measure in some of the research labs, increases 2 to 3 times, even in the youngest, skinniest, most protective individuals, which are women. And you can see here that there is significant narrowing, particularly behind the soft palate and behind the tongue. However, it's not complete collapse. So what is the tipping point that leads to complete collapse is factors that influence the upper airway anatomy. And as you can see here, individuals with sleep apnea, even while awake, walking around, have quite a narrow, this is sagittal view of the airway compared to normal controls. You can see much narrow, particularly this is the region of the soft palate, this is the nasal bone, and pretty much all this entire tube above the vocal cords right here and the epiglottis, it's narrowed, but particularly at this level as compared with a normal individual. So in awake individuals, studies have shown that the tongue muscle, this is the genioglossus, actually functions heavy duty even while awake, to maintain the upper airway open. And of course that tone is taken away during sleep, so cannot protect any further the upper airway. So to summarize, the state-related changes consisting of withdrawal of wakefulness stimulus combined with anatomical factors that reduce the upper airway caliber predisposed to upper airway collapse. These are the 2 key factors. In addition, two other factors that I wanted to go over because they are very common in patients with chronic lung disease. Nasal congestion, and that is true to some extent in scleroderma due to the skin manifestations, and in some other polymyalgia rheumatic, other collagen vascular disease, actually, I've seen people losing entirely their nasal cartilage. So as a result, there is nasal congestion, and if you try to execute a maneuver where you partially obstruct, partially only, your nasal cavity, you can feel how the posterior pharynx tends to occlude because of all that negative pressure. So this recurrent phenomenon can contribute, not causing itself, but can contribute, apart from these other factors, to upper airway collapse in the retropharyngeal region. Another very powerful factor and strongly relevant to this audience is the lung volumes. The lungs are tethered through the trachea, and simply it's a mechanical factor, and onto the muscular region of the upper airway. So when you inhale and the lung expand, that tethering through the trachea occurs and stiffens the upper airway, the muscular region. During sleep, as I mentioned, because of sleep-related hypoventilation, that tethering effect is attenuated. Imagine if you have patients with reduced lung volumes for a variety of reasons. This becomes even a more important factor. I mentioned the role of sleep, but of course, the position plays a role as well. So in the supine position, this effect would be even more pronounced as we always sleep. There are other factors related to increased surface tension that may play a role, dryness or any disease entities that affect the saliva production. It may be the case in some collagen vascular disease, and that's why I show this here, because the dryness or oropharyngeal dryness may play a role, as well as medications that impact that. And of course, there are multiple other mechanisms literally that relate to arousability as well as the sensitivity of the chemoreceptors. Don't have time to go over it, but the interaction with these phenomena is what leads to the recurrent nature. So that sleep apnea is not one or two occurrences. When it occurs, it's just some people go literally in a cyclic pattern, as I will show you in some diagrams later on. So what are the anatomical factors that are the most potent in the pathophysiology? Not surprisingly, obesity, I alluded to earlier. Fat loves all the upper airway structures. This is tongue data from the San Diego. This is a case series of forensic case series that had protected upper airway anatomy, where they dissected and quantified both histologically as well as by MRI fat content, and you can see the bulkiest region of the tongue, not surprisingly, has the highest fat content, and this is the tongue portion that's going to just retrude in the supine position as a result simply of gravity in the face of muscle disfacilitation. So, but also underneath, the fat loves to accumulate as well. Other upper airway are the lateral pharyngeal walls. We call them fat pads that literally tend, because this is a bony, the upper airway is surrounded by bony structures. Literally, fat accumulating here has no room to go but to press on the upper airway opening. And with weight loss, that opening opens up. So the fat content, the fat can affect the upper airway at multiple levels, and these have been actually tongue and lateral fat pads have been shown to correlate best with the severity of disease. Other factors relevant to this audience, people with pulmonary fibrosis are often former smokers. Well, smoking, just like it induces in the lower airway epithelium, epithelial inflammation does so, believed in the upper airway epithelium. It's a dose-dependent relationship, and actually even in former smoker, it never normalizes to never smokers if smoking cessation occurs. Another quite intriguing mechanism is that nicotine has a tonifying effect on the muscle, in general, skeletal muscle. So it is believed, although it's not studied in experimental fashion, that as you withdraw through the night from the nicotine, you lose the tonifying effect on the upper airway muscle, and indeed, sleep apnea tends to get worse. And so this could be a potential contributor as well to worsening of sleep apnea in the second part of the night. Other risk factors are craniofacial abnormalities. I alluded to in before. Children, for example, tonsils and adenoids are number one cause of sleep apnea. But in adults, apart from obesity, the next in line would be retrognathia and overbite. This is the tends to, is the anatomy of the airway that tends to be genetic, runs in the family. And here is where any other anatomical disturbances such could be skin or anything that affects the upper airway anatomy can play a role. Race, because of the influences on the anatomy, African American and Asians and Hispanics are more predisposed. It's a male predominant disease in the middle age that tends to equalize with aging and menopause. So at menopause, women catch up. We talked about nasal congestion, and any other respiratory depressants these days can play a role. And I did not include any medications used to treat muscle spasticity. they can also contribute. And there are disease entities that are more frequently associated with sleep disorder breathing. This is just a reminder that it doesn't spare anyone, including physicians. So, many providers are also affected and, understand what patients go through quite fairly well. Just a recap a little bit, most common symptoms are excessive daytime sleepiness and this unrefreshing sensation of sleep in the morning, or no matter how much they sleep, they are just not feeling refreshed. However, this is not very specific because many other conditions, such as sleep deprivation, can contribute. So more specific, although not perfect, are loud snoring and witnessed apnea, but there is a whole slew of other red flags that we use in clinic, especially if these are not, present, or patients do not have bed partners or good, reliable witness bed partners. So have to be aware and kind of collect more information in those scenarios. Or in some cases, for various reasons, and I hate to say it, but men tend not to disclose or not perceive many of these symptoms. The way we diagnose sleep apnea, the gold standard way, and this is where I'm going to spend some time showing you some diagrams and real snapshots, is on polysomnography. This is the gold standard laboratory based test we do. More often though, because of the complexities and access, we do home sleep testing, but just to know that not every patient can be a candidate for home sleep testing. In general, we tend to do this home testing in people who have a high likelihood based on symptoms and all the information and are otherwise healthy. So when there is quite complex cardiopulmonary disease and other conditions, they may not fit the profile to be tested in this fashion. Oxygen, just simple oxygen monitoring, it's not an adequate test for diagnosis, can be used for screening. And here's just to show you a classic example of a sleep study with an obstructive sleep apnea. This is what we record from polysomnography. These upper channel of squiggly lines, these are the electrical activity of the eyes, and these rapid changing signals that occur kind of, we call them in phase or like kissing waves. These are the typical rapid eye movements. Beautiful physiology here. And then you can see we record chin as well as leg muscle activity. This is the reason we record, is because we want to see when muscle hypotonia, and as in this case REM atonia, occurs. So it's very important for diagnosing sleep and categorizing the sleep stages. This is the EEG that tells us the same information. And here are the cardiopulmonary pattern channels. We have EKG, and we can glean very detailed information about heart irregularities. And here the respiratory channel, where you see here, these are some potential normal breaths, but here you can see absence of any breathing. And this is over a 1 minute page, so about 35-second long, what we call sleep apnea, during which there is an increase in respiratory effort. This is sort of the body fighting, increasing its respiratory drive in order to overcome the upper airway obstruction. This increased effort is perceived in the brain, leading to a brain big arousal here. that reestablishes that tonic stimulus and that wakefulness brings on and reactivates the upper airway. But not depicted here, I'll show next, this cycle recurs very shortly. As a consequence of an apnea, you can see pretty soon occurring a desaturation, not very severe, only from like 97 to 85. In some circumstances can be more profound. So this is what an apnea is. This is a hypopnea, which is literally a partial apnea, but nevertheless is associated with similar consequences, rapid increase in respiratory effort, leading to an arousal and then followed by a desaturation. And this is what the real disease looks like. This is a cycle, a 5-minute period from the life of an individual who is breathing about, who's stopping breathing about 3 times a minute. This is their what we call apnea hypopnea index. You can see that after each obstructive apnea, there is a big arousal, reestablishes breathing. However, the patient falls asleep again. And with that occurrence, sleep apnea develops again. So you can see here that there is what we call recurrent events leading to recurrent arousal, so-called sleep fragmentation, and desaturation, what we call intermittent hypoxia. So we define, in order to define sleep apnea, we sum up all the apneas and hypopneas, divide them by the number of hours of sleep, and we generate an index. An index greater than 5 defines sleep apnea on the sleep study. And we have different thresholds here. However, another important threshold is the degree of hypoxia that, particularly in respiratory patients, we need to pay attention for and report to the providers. So generally, when we report on a sleep study, we use these traditional standards classification by the American Academy, but as pulmonary provider, I frequently alter my grading here based on the degree of desaturation as well. Sleep apnea, it's a treatable disease. We have very effective treatments, and this is the one of them. This is the standard treatment called positive airway pressure. This is just to illustrate, it's literally a pressure blower that connects through a hose to a mask, and really there is a variety of types of machines and masks, but in general there are 3 main mask categories. The nasal pillows, like an oxygen cannula type, but bigger. Nasal masks and nasal oral that come in different, nasal type or nasal pillow type. And really does not matter which one you use, as well as there is no leak anywhere in the system, and the pressure flows and the pressure airflow go and target, without escaping, targets that region of interest that we talked about. And this MRI figure just illustrates how the increasing the pressure literally dilates the upper airway and allows the airflow to go uninterrupted. This is on a cross-sectional MRI. You can see how the upper airway size increases with administering of pressure, in this case gradually increasing. So another form of therapy that we use, particularly in milder cases, are these dental appliances. Really, they are manufactured by specialized either dentists, orthodontists generally, but ENT physicians as well. And the goal of these treatments is to reposition the lower jaw in anterior position, bring it forward in relationship to the upper jaw to open up more space in the back of the throat right here. It's easier to use and more accepted by the patients. But as severity of sleep apnea worsens, they are not as effective. So we tend to use them in people who have milder disease, who cannot tolerate CPAP. And generally, avoiding sleeping on the back, supine position is in general a target. And there are devices that help people, you attach to the back and help people avoid that position. However, in my experience, they are harder to tolerate. And lastly, we have pacemakers, literally, for the tongue, so-called hypoglossal nerve stimulators, which have been shown to be effective at controlling sleep apnea and subjective subjective symptoms, particularly such as sleepiness. This is a fairly new kid on the block we have in our clinics, and has been, however, tested in patients with a very narrow set of characteristics. And unfortunately, in my clinic, this is a rare BMI to see. So I personally do not have a whole lot of experience, just because in the area where I practice, I rarely see patients who with that BMI who feel, make it to that level of recommendation. Now, I'd like to focus the rest of the time on the pulmonary fibrosis. It is the idiopathic form for which there is the most data, however, not a lot. It's the best studied in relationship with sleep among the ILDs. It is very similar. The pattern of IPF is, histologically as well as radiographically similar to what you see in scleroderma. NSIP, you all are aware, non-specific interstitial pneumonitis is the most common among interstitial lung diseases in scleroderma. However, physiologically, for the purpose of this talk, I don't think there is much difference. Most of the studies that have been done have included only IPF, which means they excluded rheumatologic patients with rheumatologic diseases. But nevertheless, physiologically, I think they are very similar. We have still limited effective treatments, 2 drugs, nintedanib and pirfenidone, which fortunately have been accepted for use in scleroderma patients. And what's important for this talk is that frequent comorbidity that may be relevant exists, such as reflux, pulmonary hypertension, emphysema, and obesity. So let's focus on the relationship with sleep apnea. I'm just going to start by saying that simply patients with IPF, if you ask them, universally they feel fatigue. So 100% of patients with IPF report daytime fatigue. This has been shown by numerous studies in the area, and that has been correlated on sleep studies with quite disturbed sleep architecture, consisting of reduced total sleep time, reduced sleep efficiency, and these are all markers of insomnia. on a sleep study, particularly this what we call wake time after sleep onset. So no matter which parameter, there is evidence of sleep disturbances and alterations in duration and quality of sleep, as well as a reduction in the restorative stages of sleep. And in addition, interestingly, there is an increased frequency of what we call periodic leg movements during sleep. This is sort of the sleep correlate of the restless legs syndrome. Restless legs is a wakefulness phenomenon, and these PLMs are their sleep correlate in about 80% of the patients. In addition, of course, nocturnal dyspnea and cough will play a role in the sleep, and they on sleep study we see alterations in respiratory pattern as well as nocturnal oxygenation that can contribute to these symptoms. There is clearly evidence of hypoventilation in spite of increased minute ventilation, as detailed here, and desaturations for reasons we talked about tend to occur during REM sleep, but they can also happen during non-REM sleep, particularly in more advanced patients. Symptoms of sleep apnea are reported roughly by 40% of the patients report snoring, and interestingly, excessive daytime sleepiness is actually not that common. In some respects, it's less common than general population, and no one knows why that is. It's a phenomenon that also we see in patients with congestive heart failure who also have a high frequency of sleep disorder breathing, particularly central sleep apnea. And it is postulated, not proven, but postulated that is because of enhanced sympathetic activity, which tends to increase alertness. So lack of daytime sleepiness should not deter someone of thinking about sleep apnea in these patients. And like I said, the most common denominator is daytime fatigue. Here is just to show you one of the largest cohorts of studies where I believe these are like 100 patients of where they show how poor actual numbers of, how poor the sleep efficiency. Normally for adults, sleep efficiency should be at least above 85%. You shouldn't arouse more than five times an hour, and slow wave and REM should be each around 20%. So just to give you an idea, AHI, we talked that normal should be under 5, and you shouldn't desaturate more than 5% of your time. In normal individuals, not even. So just to give you some actual number from a cohort, the largest cohort of IPF patients we have. This is, again, I mentioned before, the degree of sleep-related desaturation in pulmonary fibrosis. This is the magnitude of the fall in saturation from wakefulness. You can see how that correlates, how poorly the higher the magnitude. Here, these are quintiles, so categorized in 5 categories. With this being the most profound category, you can see how the survival decreases with the magnitude of desaturation. And of all the parameters here, you can see that they tested, and I mentioned before, what correlates best with in this case, with the right ventricular pressure, systolic pressure. These are the correlation coefficients and the p-values. Let's look different way of reporting, but correlation coefficients as close as to 1 indicate excellent correlation. So above 0.7, 0.75, it's actually quite good correlation. So you can see that the degree of the fall of oxygen saturation during sleep was the best correlate with RV systolic pressure, which is very important for IPF patients, and that was surpassed not only the desaturation from 6-minute walk test, but also other PFTs and symptom metrics, and even the cardiopulmonary exercise treadmill testing, the degree of desaturation on that. So there are multiple sleep disruptors in IPF. Certainly the dyspnea and cough that inherently come with the disease as it progresses. Those are major disruptors. But also reflux, nocturnal reflux, it's a major issue, as you know. The associated psychopathology, depression and anxiety play a role, and more often these patients are obese. And of course, we are learning, and now we're going to talk about next, this bidirectional relationship between IPF and sleep apnea, where IPF predisposes, we believe, to the development of obstructive sleep apnea. And once established, obstructive sleep apnea worsens outcomes in IPF, such that these relationship is borne out from some fairly recent clinical epidemiology and animal experimental data. So let's focus first on this side of the relationship, on what is the data supporting a relationship in this direction. So there are several small but better and better characterized series of IPF patients. These are all studies that have incorporated patients defined based on the more established guidelines. As you know, there have been reiterations of in IPF definitions. So most of them, particularly this larger series, has used the 2011 iteration, and all these series simply took all comers regardless of their sleep symptoms and did laboratory-based polysomnography we talked about before, and look at the prevalence of obstructive sleep apnea. Contrast that with what I showed to have been reported in general population of 14%. In many cases in this series, majority of these patients had not been recognized, meaning their sleep apnea had not been recognized. And unfortunately, most of the cases are in the, as you can see here, most of the patients in that larger series were in the moderate to severe category. So not only that it's often moderately to, it's often of moderate to severe disease. And in clinical practice, in the US at least, an AHI in this category qualifies everyone for treatment regardless of their symptom profile and comorbidity profile. So this is clinically significant obstructive sleep apnea in the majority of these patients who had sleep apnea were in that category. As far as what can predispose patients with sleep apnea with IPF to development of sleep apnea, we have very little data and to some extent controversial. As you may ask from before, obviously obesity could be a factor. However, that relationship in this small case series has not been consistent. Obviously, lung volumes, after I mentioned to you, small lung volume is a risk factor for upper airway collapsibility. That relationship is also not very robust. And the reason could be that normally in the PFT lab, all these lung volumes are measured supine. Well, nobody are mentioned sitting or even upright. Nobody sleeps upright, and rarely they sleep sitting. So the correlation is not going to be as powerful, maybe because of that. So what was interesting, though, that even though in a small subset of patients in this cohort, if they remove the potential contribution of obesity, looking in the leaner patients, there seemed to be a better correlation between low lung volumes and higher apnea severity. So still something that needs to be researched and understood much better. Another contributor talked about mostly before and maybe more relevant to this audience is the effect of inhaled, actually and oral, particularly corticosteroids, because I showed you in that upper airway region, any extraneous tissues such as fat are going to put pressure on the upper airway size and narrow it. Corticosteroids systemically particularly can alter the fat content and the distribution, not only from periphery to the central, particularly neck region, and can contribute to increased upper airway pressures and collapse. So the effects of corticosteroid needs to be better understood, and it's very likely to play a role. Now, looking in the opposite direction, what is the data to support that once established sleep apnea affects IPF outcomes? And really that data borns out from several, again, very small, non-randomized studies showing, though, suggesting a benefit of CPAP treatment for OSA on IPF outcome. And I selected this study because it's a larger study. We have, again, using the newest IPF definition guidelines, of the 92 patients I shown before, about 65% had moderate to severe sleep apnea, and they were offered CPAP and followed up to 2 years. Again, this is their profile of symptoms at baseline, and they were fairly adherent with CPAP. We measured that objectively through chips in the machines, and we defined that in the standard. This is the standard definition: at least 4 hours a night, 70 nights of the week. So of the patients, of these 60 patients that they treated, 37% had good usage, and 18% were poor users, and I think they had some dropouts. So this is what they reported. You can see that in patients with good compliance, survival up to 2 years was 100%. However, in the patients with poor compliance, about half of them died up to 2 years, and they had significantly improvement in pretty much all the questionnaire scores that they measured. This is functional outcomes as they relate to effects of sleepiness on daytime activities and performance. Sleepiness improved, daytime fatigue and depression, as well as quality of life. So how can obstructive sleep apnea worsen the pulmonary fibrosis. I think this is a very interesting area because it really impacts potentially response to current antifibrotic treatments for reasons I will emphasize. Well, indirectly, sleep apnea worsens GERD, literally closure in the upper airway through the negative intrathoracic pressure. Really, literally what it does, suctions all the stomach content in the esophagus. It can also, sleep apnea worsens pulmonary hypertension, and sleep apnea is a known risk factor of systemic cardiovascular disease. All of these can worsen pulmonary fibrosis, but directly, sleep apnea through that intermittent hypoxia feature that I showed you has the potential to worsen fibrosis, and we will go over some data that we recently published in an animal model. And in addition, that recurrent change in respiratory effort during an apnea has been suggested to induce injury in the alveolar epithelial cell and predisposed to inflammation that in turn could perpetuate, that epithelial injury could perpetuate injury and subsequent fibrosis. So this is a study that we published not that long ago, where in a Sprague-Dawley rat, where we induced pulmonary fibrosis using a commonly used drug for this purpose, bleomycin, and 5 days after this lung injury, we subjected the animals either to normoxia or to hypoxia, and of course, because of the two interventions, bleomycin versus saline and normoxia versus CIH, we end up with 4 control groups. Day 14, kind of in the middle, and at day 35, we subjected these animals to pulmonary function testing, as well as lung tissue collection for collagen content and markers of fibrosis, as I will show. It's important to note that the severity of sleep apnea model here that we use, it's about the moderate range, which is based on that clinical data that I showed earlier, where the majority of the patients are in that category. So we really replicated in this model the clinical model that that has been published. So I'm going to show some physiologic data. This is, as you know, when the lung becomes fibrotic, becomes stiffer. That means it is harder to inflate and more easy to deflate. So harder to inflate means reduced compliance. So as you can see here, as early as 14-day, bleomycin, regardless of the CIH treatment, as expected, had an effect because it stiffened the lung, made it less stretchy. However, at day 35, in this model, in the normoxia, under normal condition, it is very well known that some resolution of fibrosis occurs. So by this day, in the normoxia, bleomycin injured animal, there is some catch up, some improvement in the compliance. Such effect was abolished by the CIH, meaning the lung continued to remain stiff. The converse measure of compliance is the elastance, meaning how rapidly or how easy the lung, once stretched, returns to its steady state. And as you can see, again, at day 14, the lung is very rapidly returning to the rapid state, to the baseline state, because it has become fibrotic and stiff. And such effect is still prolonged, not as significant though, but still prolonged in the bleomycin injured animals by the CIH. This is just a representative diagram from the two animals treated with bleomycin. Of course, as you can see, for the same change, for the same pressure, inflating the same, the sort of the balloon, the lung with the same pressure, we are able to change the lung volumes much more, induce much higher lung volumes in the normoxia as compared to the CIH treated rat. So this is another indication that the CIH bleomycin treated rat lung is quite stiff. In a smaller subset of animals, we had the opportunity of collecting their exhaled gas. And as you can see, so normally as you collect exhaled gas, so that gas should be quite rich in CO2 and less so in the O2 because you exchanged under normal conditions. However, you can see that if the gas exchange is altered, you are going to collect less carbon dioxide and more oxygen, which is what happens here. As you can see with the bleomycin treated groups, we collect more oxygen and less carbon dioxide, particularly in the bleomycin CIH group, indicating that the gas exchange lung barrier is altered. Oops. So I mentioned that we quantified the total lung collagen content. This is a standard assay, you may know, hydroproline content. Literally in the entire lung level, we, harvested, snap froze, and ground all the lung, and you can see that by day 14 in the bleomycin injury there is a tendency towards an augmented collagen content in the bleomycin CIH as opposed to the normoxia. And the day 45 and the day 35, this difference became even more pronounced and was statistically significant. So in a nutshell, the CIH augments the lung collagen content in the bleomycin treated rat. Here, looking at the pathways that could lead, you may be familiar with fibrotic growth factors in response to any injury, particularly bleomycin. TGF-beta is one of the growth factors that are expressed by the epithelium quite rapidly, and downstream is this CCN2 growth factor that is also expressed. And day 14, we have increased expression by bleomycin, not much difference in the CIH treated group, but at day 35, this difference is quite significant, and while as expected in the normoxia bleomycin there is some resolution as indicated by the other testing. Moreover, we looked at a couple of collagen isoforms to get more specifically as to which ones may be affected the most. As you know, collagen 1, 2, and 4 are the most common isoforms in the lungs, and we measured the collagen 1. No differences at day 14, however, expression was augmented by hypoxia at day 35. Collagen 5 is another isoform that is not that prevalent and is kind of hidden in the collagen bundle. However, if exposed under different conditions, can become a factor that can induce autoimmunity and perpetuate fibrosis that way. And there is some indication here that that expression may be augmented by hypoxia at the end of at the endpoint that we have. So in summary, sleep disturbances and disorders are common in patients with IPF. Sleep apnea is a common contribution to that, and as all the other sleep disorders, often unrecognized. Unfortunately, symptoms, I didn't have time to go over that, are not predictive of the diagnosis. None of the questionnaires that they used to assess sleep apnea risk correlated very well with the sleep study data, therefore cannot recommend screening based on questionnaire. Literally, you just have to do a sleep study, and sleep apnea relates with worse survival in IPF, and mechanisms, at least in part, relate to the intermittent hypoxia component, which seems to trigger collagen overproduction, leading to physiologic alteration and gas exchange ultimately. I want to emphasize that data are limited, and more research in larger, well-characterized samples, which is indeed challenging to achieve, and more mechanistic studies are necessary. And I wanted to go in the only study that I found looking specifically at the scleroderma spectrum disease, suggesting that there may be an increased risk for sleep apnea in this population as well. This is really a small cohort of patients. I believe they were, and it's a retrospective chart review where they looked at these patients, and you see their baseline characteristics. Majority had limited disease, and they also had two subsets. One of the patients, one subset had performed forehead nocturnal oximetry. As you know, because of the sclerodactyly and the Raynaud's, is very hard to record oximetry at finger probe. So generally in these patients, it's either the ear probe or forehead. So they had about 53% of these patients had abnormal nocturnal oximetry as defined by the equivalent index on this test called oxygen desaturation index. And it seemed to be that the older age was the only predictor of abnormal nocturnal oximetry results. From these subset of 53 patients, I believe, 17 of them went on and had sleep studies with polysomnography. And you can see that their baseline characteristics. Again, I want to emphasize that as compared to any other chronic lung disease that I've worked, this is very lean BMI. In asthma, for example, the average BMI of the populations I've studied is about 31, 32. IPF, in this, my practice at least, it's about 30. So this is a very lean population from a sleep perspective. Most of them had actually interesting, well, small numbers, but UIP and NSIP. And I just wanted to show the degree of sleep disturbance here that they have in sleep apnea. The mean AHI was quite high. This is in the clinical range. 15 is the clinical range for which treatment is recommended regardless of symptoms and comorbidities. They spent quite a lot of time hypoxic, pretty in the moderate desaturations, and very poor sleep architecture and sleep parameters. And some of them went on and were prescribed pretty much CPAP, but not all of them used it. So limited study, but just to emphasize and sort of set a red flag that this risk for sleep apnea among scleroderma patients may exist. Since this is an educational series and I'm heavily involved in education for both patients as well as healthcare providers, I want to alert you of Carrie and I, we actually connected through this wonderful society, which is the American Thoracic Society that Carrie and I very proudly serve. I'm very involved. We are organized in 14 groups based on interest. I'm obviously part of the sleep and interest group, and as part of that, what we call assembly, we have produced a variety of content. And I'm not sure, Carrie, do you see the page? Do I have to?
Yes, we can see that. Yep.
Okay, so so if you take a look right here under patient education materials, we have compiled several series for patients. The first panel, the first set, is educational links from a variety of the most credible resources. There's a lot of sleep content out there, right? So you don't want to go in resources that really haven't vetted what they are, the content that they put out. So these are very credible resources where you could read on a variety of sleep topics, starting from the National Institute of Health, National Sleep Foundation, and our professional societies, variety of very credible universities. And you can take a look at, whichever topic may interest you. And we have quite a variety. If you have children, we have data on those as well. Going back here in the second data set, here it's a very informational set of literally pamphlets that we actually have translated in a variety of languages. I don't know if you have, is this an international audience, Carrie, that you have?
Yeah.
Okay,
yes,
wonderful,
yep.
Because we are, while we are working on expanding with ATS the language reach, we have some, and particularly on the sleep apnea, and as you will see here we have narcolepsy, and a variety of respiratory disease-related neuromuscular weakness. We've done obesity, hypoventilation. I don't think we have one yet in sleep in IPF, but now that I'm thinking that should come. We have sleep apnea and heart disease, sleep apnea in asthma and COPD, and here are some pediatric resources. And lastly, I think I need to go here. It's just a brief description, very well done video by one of our best, best assembly members interviewing a patient with sleep apnea. And in many cases, people relate very well when they hear such stories. So please take a look at these resources. Carrie, and my email and my name is on the web. I'll be happy to take any questions here as well as down the line. So thank you very much, and I appreciate your interest and time.
Well, that was a fantastic presentation. Thank you so much, Doctor, for your time with us today. I know we're just a little bit we're past the hour. However, we did get a couple of questions, and if I can I squeeze a little bit more time with you to share with us
Oh,
today to get some of
absolutely.
those? Okay, great.
I'd be happy to.
Wonderful. So we have National Team Office member Angel Soto, Programs and Service Associate, here to facilitate the questions. Angel?
Thank you, Carrie, and thank you for that wonderful presentation. We had plenty of questions, but I'm going to try to narrow it down to the most popular ones to respect your time. But
Sure.
First, the first question we had was I'm experiencing so many sleep issues, but I don't know where to go. Should I go to my rheumatologist, a sleep expert, a pulmonologist?
To some extent that depends in which area of the world, and we are practicing. Like I said, in the US, the referral pathways and treatment guidelines are different from even Canada, for example. But always, it's a good point to start with your primary care. And I would anticipate that if they don't know or are not familiar with, they would just initiate a referral to the appropriate specialist. As far as choosing among sleep specialists with different backgrounds, that's gonna depend, and it's more delicate. So I would also, talk to your primary care, let them guide you in that direction, because there can be tricky. But a start point, I think the best is with your primary provider.
Thank you. And another question we received quite a lot, and I'll make this the final question. As compared to in-lab and at-home tests for sleep apnea, do all medical facilities have these in-lab tests, or do I have to go to a special location?
They are pretty widely available. I think, in the US, and certainly maybe even more available abroad, because the sleep labs are less abundant abroad. So, and in the US, I think it's, part of our standard practice these days to incorporate portable technology. So they should be quite available pretty much everywhere. But again, you will need to be referred, and generally the sleep centers will be the ones who will look on your case and triage, what we call, which person is best suitable to be tested in the lab versus in the laboratory versus at home, and they will make that decision jointly with the insurance company as to how they would like to cover. So the technology is out there, it's pretty available, and with COVID, actually, we initially, everywhere in the world, I suspect, certainly in the US, we initially shut down for, I forget, a month or two, and when we restarted, actually, we restarted entirely with portable technology. So I think the technology is widely available.
Excellent. Thank you, Angel, for facilitating the question and answers. In closing, I would like to thank Dr. Mihaela Teodorescu for sharing your time and expertise with us today. Thank you to the attendees that logged on or dialed into today's event, and special thanks to our Diamond National sponsors, Actelion Pharmaceuticals US and Boehringer Ingelheim, and our corporate sponsors, Corbus Pharmaceuticals. As a reminder, we'll be hosting these virtual university webinars weekly. Next Wednesday, September 23rd, we will have Dr. Sundar Balasubramanian from the Medical University of South Carolina. He will be joining us to host a seminar on gentle yoga and yogic breathing for scleroderma symptom management. Please stay tuned and connected with us through our website, scleroderma.org, and the social media outlets to stay informed on our virtual university patient education fall series, as well as our great chapter of virtual events happening now across the country. This will conclude today's webinar. Be well and have a great day. Thank you.
Thank you.
Thank you.